or younger patients having very severe influenza in intensive care. And it will be interesting when we get the data at the end of the season to see about mortality, especially in the younger patients after this flu season. So if you look at this graph of the 2017 flu season, you can see the orange bars, and you can see that there's actually a lot of flu B this year, more than what there have been in other years. You can also see that there's quite a sustained peak, and that the peak begins at about week 31 or 32, but it kept going strong up until about week 39. So it's a fairly long peak. And you can also note here that cases have been above average from about week 28 up until about week 39. If you compare this to 2016, this is the entire 2016 season, you can see that there was less influenza B. You can see that it peaked at about week 35 and that it was sort of a fairly normal distribution in terms of the shape of the flu season, and it ended in about week 43. But you can see that in the entire season there was only 1,751 cases, so a lot less than what we've had even to date. And once again, about the same number admitted to ICU, but more in pregnant women and Indigenous people. So in terms of background, when talking about influenza and antibiotics, as all of you know, viral respiratory tract infections is one of the most common causes why people go and see their doctor. And during epidemics, attack rates are pretty high, especially in children. But we know that antibiotics are often prescribed for viral infections, especially influenza, and this constitutes a large part of antibiotic use in the community. And the very young and the very elderly are more likely to develop complications secondary to influenza. And as sort of fate would have it, I developed influenza on Monday afternoon, and it was sort of like maybe cursing me for giving this talk. So in terms of secondary bacterial infection, it's known that influenza actually alters nasal patency and also leads to eustachian tube dysfunction. It changes pressure in the middle ear, and it causes an accumulation of fluid in both the sinuses and the middle ear, all of which can promote secondary bacterial infection. We also know that severe bacterial superinfection after influenza occurs, but of course the art, and especially the art as clinicians, is in distinguishing these bacterial complications from the direct effects of flu, and that obviously directly affects prescribing decisions. In terms of complications of acute influenza, I found US data, and that is that bronchitis and pneumonia cause about 150,000 hospitalizations a year, and with many deaths every year. So in terms of what data there is out there about influenza and antibiotics, there was a paper in Pediatrics in 2003 looking at the use of rapid diagnostic testing in influenza and determining whether or not it altered management, specifically whether or not it altered antibiotic prescribing. So in this study, they had children presenting to the emergency department, and in this RCT, they basically had one group that had the rapid tests done with the results available by the time the doctor came in to see the patient, and in the control group they had their nasopharyngeal aspirate sent off to the lab for flu, obviously with no results available to the clinician at the time of review. Once the doctors were aware of the diagnosis of influenza, antibiotic prescribing decreased and antiviral prescribing increased. And that seems fairly sort of intuitive to all of us. There was a study using US ambulatory care data in a federal survey from 1997 to 2001. And this was published in Respiratory Medicine in 2004. And they looked at patients who were diagnosed with influenza only, and these are all ambulatory patients between 5 and 49 years of age. And more than a third of visits led to an antibiotic prescription. And remember that in this cohort, they were all diagnosed only with influenza. And in about 38% of cases, they were actually broad spectrum antibiotics. A third got antivirals, and that, you know, they suggested that the inappropriate antibiotic cost was about $18 million annually. They also classified the antibiotics that they prescribed in this study as broad spectrum and narrow spectrum, remembering what they said was that 38% were for broad spectrum antibiotics. Interesting here, I've just placed arrows just to indicate, and obviously with the size of the US population, different to Australia, but we could extrapolate from this. The number of visits to a physician's office is over 5 million, and the number of visits to an emergency department is nearly 700,000 over that time period that they were studying. So a substantial number of ambulatory patients seeking medical care during the influenza season where they only have influenza. A paper in the New England Journal of Medicine looked at the effect of influenza on hospitalisation, outpatient visits, and also courses of antibiotics in children. And this was a retrospective cohort study of healthy children who were under 15 years of age, and they wanted to determine the rates of hospitalisation for acute cardiopulmonary conditions and also courses of antibiotics. And they looked at 19 years worth of data. And this was a Medicaid population. So for those that don't know, Medicaid would be an uninsured healthcare card holding population, usually lower socioeconomic status. The number of courses of antibiotics that were attributable to influenza-associated illness ranged from about 3 to 9 per 100 children. And children of all ages were more likely to receive antibiotics and prescriptions during a flu season than at any other times. There were then some studies on the impact of antivirals, the first one being zanamivir, and although we don't use zanamivir very much at all, there was still some data that I think was interesting, and this was looking at adolescents and adults. And what they did was they did a meta-analysis of 7 RCTs where they had 2,500 laboratory confirmed cases of influenza, once again in an ambulatory population. Now, in some of these 7 trials, there was a lower rate of antibiotic prescriptions occurring among recipients of the antiviral than among those that received placebo. In the meta-analysis, they found that respiratory complications or a worsening of symptoms led to antibiotic use in about 17% of the adolescents and adults that were studied who had influenza. Antibiotic prescribed were most often penicillins, followed by macrolides, cephalosporins, tetracyclines, and you can see that even quinolones were prescribed for patients who had influenza. So some very interesting antibiotic choices. But they found that early treatment of influenza with zanamivir reduced the number of these antibiotic prescriptions. And what was interesting, and I think it's interesting when you look at the data to critically appraise how they collected it, when we talked about 17% of patients, so on this slide where I say 17% had symptoms that led to antibiotic use, this was all based on physician-diagnosed complications of influenza or physician-diagnosed worsening of symptoms. So you can see that we could probably do a lot better than just physician-diagnosed because it wasn't necessarily based on hard objective data. Remembering, of course, that these were ambulatory patients, so they're not inpatients. And also, half of the events that led to prescribing of antibiotics occurred within the 6 days after the onset of symptoms. And so you would kind of assume that a lot of them could very much be viral bronchitis and acute sinusitis. What's also mentioned is that early antiviral treatment actually decreases levels of interleukin 6 and 8 and also tumour necrosis factor alpha, and that therefore the antivirals actually have a direct effect on decreasing complications that are promoted via these inflammatory mediators. So that brings us on to obviously the efficacy of other antivirals. So there's numerous trials on the efficacy of oseltamivir, and you're probably all aware of it, but I thought I'd just go through a couple of them. In JAMA in 2000, there was a randomised controlled trial of oral oseltamivir in patients with, once again, community-acquired influenza. So we're not talking about a hospitalised population. Here there were over 600 healthy, non-immunised adults between 18 and 65 years of age who came in with a febrile respiratory illness that hadn't gone on for more than 36 hours, that had temperatures of 38 degrees or more, with at least one other respiratory symptom and one constitutional symptom. And they found that in giving oseltamivir, the severity of illness was reduced by 38% when they used 75 milligrams BD, which is the standard dose for treatment with oseltamivir. And actually in this trial, they were comparing it to 150 milligrams twice daily, and they found that didn't improve symptoms any more than the lower dose did, and that's the reasoning behind 75 milligrams BD. They found that oseltamivir reduced the duration of fever and that the patients returned to their usual activity 2 or 3 days earlier. And the secondary complications of bronchitis and sinusitis occurred in 7% of patients that got oseltamivir, compared with double the number of placebo recipients. What was interesting in this study, just looking at the methodology, the participants had to record 7 of their influenza symptoms using a 4-point scale, so including things like nasal obstruction, sore throat, myalgias, etc. And they had to do that for 21 days. They also had to take their temperature with a digital thermometer and record it in a diary. And they had to record their capacity to perform usual activities using a scale as well. So there was a lot of data that was recorded by the participants themselves. And once again, the conclusion was that there was a significant reduction in respiratory complications leading to antibiotic prescriptions. You can just see here, looking at, for example, complications, so sinusitis, bronchitis, obviously very small numbers, only 1 patient with pneumonia, but you can see the reduction in secondary complications that would normally cause antibiotics to be used were reduced in patients that got antivirals. So then there was a study in the Lancet as well, and this was published also in 2000, and this was over 700 previously healthy non-immunised adults that had a febrile influenza-like illness of up to 38 hours duration. Once again, oseltamivir effective and well tolerated. One of the comments at that time was that there was no paediatric data, so very shortly afterwards there was a study published in Paediatric Infectious Diseases of children aged 1 to 12 years, and the incidence of physician-prescribed antibiotics was significantly lower when they treated patients with oseltamivir. So that does, if oseltamivir is so wonderful, why is it not perhaps more widely used? So I thought I might just mention a little bit about the cost of oseltamivir. So as you probably all know, it's non-PBS listed in Australia. It was rejected most recently in 2008, and I'm not sure if there was a previous rejection of it before 2008, but they may well have been. But I've looked up data from 2008. What we know about the cost of it is that if you've got a private prescription, the cheapest that you can get oseltamivir is about $43 at Chemist Warehouse, and for me on Monday, $53.95. So that's a 5-day course. If you go to a hospital pharmacy, with the government subsidy, it'll cost $38.80. And if you're a healthcare card holder, it would cost $6.60 in the hospital pharmacy. In America, it's between $110 and $120 US for a 5-day course of oseltamivir. What was mentioned in the document from the PBS, from the submission to the PBS, I thought I'd put it here so that we can at least be aware of the reasons for the rejection. So their concerns were that there's likely to be a large number of presentations for influenza-like illness that are not influenza, and that treatment's only effective if patients start the treatment within 48 hours, and the possibility that many of these patients won't actually have influenza, and that using oseltamivir in non-influenza, there's no evidence of clinical or cost effectiveness. The other bits that were included in the statements that I read was that the studies have been done on healthy, non-immunised adults, and there were some concerns that the efficacy might be different in patients that had numerous comorbidities and those that would not have been included in the previous randomised controlled trials. But the concern was largely that when we do testing for influenza, because of the lack of sensitivity of the rapid testing, the PCR takes several days, and by that time it would be too late to commence oseltamivir, so that we're basing it largely on sort of clinical data at the time of presentation. So that was a good segue for discussing delayed prescribing of antibiotics, and just mentioning that this paper that I read from Chris Delmar's group, I think from Bond University, where they talked about whether or not Australia is ready to implement delayed prescribing in primary care, and where they review the evidence. And there's not a great deal of Australian evidence so far, although there's a great deal of international evidence regarding the safety of delayed prescribing in primary care. So I thought that I might end with some of the possible solutions, all of which probably all of you have thought about, but specifically in relation to influenza and the fact that we have a fairly predictable influenza season every year, albeit with different numbers and potentially different strains. We still have a fairly predictable time of year when we know we're going to get a lot of cases of influenza. So some of the thoughts were targeted GP education prior to and during the influenza season. Also targeting the emergency departments, knowing that patients go mostly to GPs and to the emergency department, especially in Australia. We probably have less patients attending an outpatient clinic, but that these might be the most appropriate targets for really directed education at the time of the flu season. I suppose the other one was a prescribing advice hotline for GPs. Potentially, this could be something that was only available during the flu season, or perhaps more widespread than that. There is a medicine-wise, so an NPS medicine-wise advice hotline, but that's actually for consumers, not for GPs. And it's led by nurses, but occasionally consumers can be connected up to a pharmacist or a doctor if required, but that is a consumer hotline, not a GP hotline. Obviously, delayed prescribing, as I just mentioned before. Vaccination for all, so not just adults and those with comorbidities or healthcare workers. Encouraging the use of laboratory testing, although adding more laboratory tests for ambulatory patients will cause a lot of laboratory congestion and will be extremely labour intensive, and it doesn't have any infection control implications, as in they're not being admitted to hospital, so we don't need to know that they definitely have influenza. But of course, laboratory testing would assist in the appropriate prescription of antivirals. However, the current delays that we have make this something that we really can't do. But I suppose that brings up improved rapid diagnostic tests for influenza being the most obvious thing that could be done to improve antibiotic prescribing. And then, of course, supporting the increased use of antivirals. And although there is some resistance to oseltamivir that has emerged, overwhelmingly it is still very much an effective agent, and it does reduce the complications that would lead to antibiotic prescribing, and use of antivirals on their own reduces antibiotic use. But of course, the cost of the antiviral itself is still a barrier. And that's the end of my talk for today.
Thank you, Deb. We have one question for you. And the question is from Pauline, who's attending online. The question is, in the hospital setting, I often see patients on concurrent oseltamivir and antibiotics. Is there ever reason to be on both treatments? Most often, patients don't have confirmed chest infections.
Yeah, that's a very good point, and I think that that's often the experience of clinicians in hospital. That is what we see. I think, I suppose one of the ways to answer that is that the majority of patients that actually get admitted to hospital during the influenza season are often suspected to have a bacterial complication like community-acquired pneumonia. So in the case that bacterial superinfection is suspected or diagnosed, it would be appropriate to treat them with antibiotics. But I think even in hospitals, we could probably do better at really limiting the antibiotic use to those where we really believe that they do have bacterial superinfection. I think, unfortunately, and this is the case with many other conditions as well, the ability to make that assessment in real time can be very difficult when you've got a very sick, febrile patient.
All right, thank you, Deb. Glenn.
Is there any evidence that oseltamivir makes much of a difference in vaccinated people?
The question yeah, all right. I'll repeat I'll repeat the question for the attendees. The question was, does oseltamivir make a difference in vaccinated populations?
So the majority of the data on oseltamivir is in non-immunised adults. My understanding is that it's the same effect in immunised adults, but I would have to clarify that. That is a very good question, however.
Deb, it's Kaz here. Can you just remind me what the current ILI definition is in Australia now?
So it's a febrile illness where your temperature is more than 38 degrees, where you've got at least one constitutional symptom like myalgias, and where you've got at least one respiratory or upper respiratory tract symptom, such as shortness of breath, nasal obstruction, etc. So it can be difficult to distinguish influenza from some of the other viral causes, but typically influenza is a much more severe illness. But based on the clinical definition of an ILI, you can't really determine it from the clinical definition. It's often based on sort of clinically assessing a patient and determining that they have a much more severe illness than what you would expect for, you know, some other rhinovirus or coronavirus type infection.
All right, thank you, Deb.
No problem. Just click forward, click back on
that. Our next speaker is Leslie Dowson, who is an NCAS PhD fellow based at Monash University. Leslie's topic is human factors in implementing AMS in long-term care.
We've lost the screen. Oh, no, there.
Thank you. I think Arjun covered it, that I'm the PhD student working in the aged care space currently for NCAS. And I've chosen to look in depth at a recent paper that has been e-published in Clinical Infectious Diseases, which is the official publication of the Infectious Diseases Society of America. It's implementing antimicrobial stewardship in long-term care settings and integrative review using a human factors approach. The authors of this, particularly Morgan Katz, is a known person in this space. They work out of Johns Hopkins in Baltimore, Maryland. And this was, in fact, an invited article, which I'll talk a little bit bit later because it was done to fill a particular need that they're facing in America at the moment. Just quickly, just a quick word on terminology. Long-term care is a difficult thing to define because certainly in North America it tends to be a catch-all. So it can include anything from a rural or regional aged care home, which is relatively on its own, to something as big as, you know, a veteran affairs hospital or what they call long-term acute care hospital. So something akin to what we'd see at maybe the subacute sites at Royal Park or at Kingston Centre. So it tends to be a very broad definition, which has its challenges in trying to define particularly the resources that are available to them. But in summary, antimicrobial stewardship in long-term care does have distinct challenges that are related to the health system. So when you think about those independent aged care homes, they don't have access to specialty infectious diseases clinicians on a regular basis. Their diagnostic and pathology facilities are off-site, and they tend to be lower resource environments. The residents themselves, the people who live or spend a lot of time in long-term care facilities, they tend to be older, they tend to be vulnerable to infection, but at the same time they can have sort of vague and atypical signs and symptoms of infectious illness, so they don't necessarily get fever. They'll have things like falls and delirium, which can make it difficult. And particularly in aged care, families in Australia have been are often sort of key players in the decisions to treat or not to treat, and there certainly is some anecdotal evidence about families asking for antibiotics in certain situations. And lastly, the care providers, so the people who provide care into long-term care facilities. Prescribers are usually off-site. They can be overly cautious in vulnerable population. And there's good evidence to suggest that a lot of them develop habits. So they do things because that's what they've always done and not necessarily because it adheres to a guideline of some sort. So those are some of the challenges. And as I said before, this was an invited paper. And the reason why it was written was because in 2016, the Centers for Medicare and Medicaid Services in the US made AMS a requirement for long-term care facilities receiving funds from Medicare and Medicaid. And what particular that they are requiring is that every long-term care facility has an infection prevention and control officer and an antibiotic stewardship program that includes an antibiotic use protocols and a system to monitor antibiotic use. Further to that, because I was curious about what they actually meant by antibiotic use protocols, I looked it up and it says antibiotic use protocols are intended to verify the appropriateness based on clinical indication, laboratory finding, duration of use, and national standard. So they're moving towards this requirement of AMS. And I thought interesting, the requirement in Australia could be fulfilled by participating in ACNAPs, because what they're looking for is just some kind of system to monitor antibiotic use and its appropriateness. And I guess further to that, in Australia, we are looking at updated Australian aged care quality standards, which are scheduled to come in 2018. And certainly there have been people here at NCAS who are trying to make sure that AMS and appropriate antibiotic use get included in the standards. The latest advice that I have is that those are still being refined and set to be released next year at some point in time. So anyway, in the space of long-term care facilities, we are really looking towards implementing antimicrobial stewardship and antimicrobial stewardship programs. But the reality of it is that we actually don't know what works. In America, they seem to be looking at this as a patient safety problem, and patient safety problems are complex and are rarely caused by one factor or component of a work system. So what happens is that there is currently no gold standard for AMS in long-term care facilities, and that AMS in long-term care facilities, any interventions that have been tried often consist of multiple components, including a structured education. So there hasn't ever been one consistent thing that we know that works over and over and over again. So the point of this paper was then to have a look at how could everything that's been tried be classified down into our patient safety matrix, and we can try to find out what specific works or what specific recommendations can actually be made for AMS in long-term care facilities. So this is the system that they use to classify the various interventions that have been tried in long-term care facilities. And it's a system engineering initiative for patient safety. And what it is that they break down the different interventions that have been tried into 5 different, what they call work system components. So various tools and technologies, which are objects that individuals use to carry out their work. So this is something like an alert on electronic health record or a pocket card describing antibiotic prescribing guidelines. They look at various tasks that people have tried, so specific actions within a larger work process. So like the act of administering a medication or a checklist of antibiotic monitoring criteria. They looked at the organization themselves, so if there's anything that can be done within the organization, so structures put in place to organize either the time, space, or resources, the cultural infrastructure of the facility, or a communication between individuals. And they suggested an example of this would be like an incentive program for following antibiotic prescribing guidelines. They look at the individual characteristics of the people working in long-term care themselves, such as their knowledge, their expertise, or their training of the people who work there. And then they looked at the environment themselves, so the physical or external environment where the work is done. So the physical placement, for example, of an educational poster on a wall in the common area. So they completed a literature review and they classified each of the interventions based on this system, and the inclusion criteria of their literature review was that they had to be primary research studies, they had to be describing AMS interventions in long-term care facilities, they were all English language, and they had to have a quantitative outcome measure. So in total, they found 20 studies that were included in their review. Sorry, 5 of them were randomized control trials. There was 15 quasi-experimental studies. They did do this measure of quality assessment, although it wasn't immediately obvious about how they used that. So they used the quality assessment from the National Heart, Lung and Blood Institute. In addition to the work system components, they had a look at what education was provided in each of the study, and they found that 16 studies had a structured education intervention, 7, it was the primary intervention, and 14 of those studies included nurses. Most of the studies had elements beyond education, and of the 20 studies that were done, 14 had measurable change. But that measurable change included various things from reduced antibiotic use, better adherence to guidelines, reduced level of C. difficile within the facility. So again, it's sort of varied about how they look at what is a measurable change. I'll just maybe highlight 2 of these studies, which are the more famous, well-known studies in this space, particularly the LOBE study that was done in 2005, and that was a randomized control trial that looked at reducing antibiotics prescribing for urinary tract infections. It was a clustered randomized control trial. And they used an algorithm for diagnosis and treatment in that particular study. And what they found is that they were able to reduce the number of prescriptions for urinary tract infections, but they didn't reduce the overall number of antibiotic prescriptions in the intervention facilities. And the other one, which gets looked at quite a bit in this space, is the Monash study in 2007. And again, that's a randomized control trial that was done where they mailed the prescribers guidelines and also how well they adhered to the guidelines. So it was a simple mail out to the prescribers. And again, they found that they were able to achieve a significant difference in the non-adherent antibiotic prescriptions. So what they did was that they took all 20 of these studies and they classified them according to these work systems. So they went and had a look at that engineering system for patient safety. And on this figure, the interventions which are in bold are the ones that were actually successful, where they had a measurable change. The ones that are not in bold, there was no change, so they were ineffective at having a measurable change, so having a better outcome. So looking at tools and technologies, they've tried prescribing guides, they've tried pocket cards. The antibiograms and the data gathering forms were unsuccessful. Pre-printed order sets and electronic medical record used to facilitate chart review and communication, have all been successful. Looking in the space of organization, local stakeholders to develop an action plan, that was unsuccessful. Engaging facilitator leadership, involvement of ID experts, including of residents and family members, those were all successful. Looking at persons, ID experts, again, involvement and feedback has been successful. Multidisciplinary education and data-driven feedback to individuals have all been able to produce a measurable change in this space. Looking at tasks, pre-prescription data gathering incorporated into the nurse's workflow, post-prescription recommendations incorporated into the prescriber's workflow, and in looking at the space of the environment, posters and other educational materials displayed in work areas, as well as resource abundance. So again, you come back to trying to define what is a long-term care facility. Places with better resources tend to have better outcomes. The other interesting thing about this, which was one of the, I guess, drawbacks of this paper that I had difficulty understanding, was that in their conclusions, they said that the 6 interventions, which included these organization aspects, so the communication between individuals, and the person aspects, so individual characteristics, were actually the most successful. So they were most consistent and most effective at their AMS outcomes. But interestingly enough, when they go on to say what actually are the effective approaches, they actually include some of those task-related interventions as well. So these are the 4 approaches that they recommend above all others. So multidisciplinary education supported by enduring materials, integrating a pre-prescription data collection material into the nurse's workflow, integrating a post-prescription recommendation into a prescriber's workflow, and employing external specialty infectious diseases clinicians. So a word on the multidisciplinary education. The recommendation is that we shouldn't be just trying to target one particular group. So it needs to be everybody all included, because that facilitates communication within the long-term care facilities. And also, any sort of education that has to be done has to be supported by something that is enduring. So if you do a one-off education system, you're going to get diminished returns over time. So whatever you do, you want to try to get something that is long-lasting. They look at both nurses and prescribers. Nurses in long-term care facilities are quite powerful. They make daily care decisions. And what they mean by incorporating data materials into the nurse's workflow is they had a few of the studies use checklists or a data collection form, which you would go through and look at what signs and symptoms of infection the resident had before communicating that onto the prescriber. And in one of the studies, which was really interesting, was that they found that the nurses weren't actually completing the checklist, but they were using the checklist to communicate the signs and symptoms to the prescriber. So it wasn't necessarily the process of going through and checking it, but it was actually giving them a system to talk to the prescriber about possible infections in a structured way. And then, of course, employing external specialty infectious diseases clinicians, of course, they have to be available. So you have to be able to make sure, again, that's a resource issue, and you need to make sure that if that is going to work, they have to be available to the long-term care facilities. But the great thing about this is that all 4 of these could actually be bundled together into one intervention into a long-term care facility if you are going to try to implement an AMS program. Just a little bit more about the discussion is that there is some research as well, again, bringing up the point of the multidisciplinary education and making sure that you include all the different disciplines in an AMS program in long-term care facility, is that long-term care facilities that support communication among the different roles have lower rates of antibiotic use. And this is also supported by some work that's been done out of Europe on hierarchy and etiquette and the impact of the effectiveness on AMS interventions. So it tends to be that if you have a more egalitarian system, people are more likely to communicate and to speak to one another, and they found that AMS interventions can be more successful, or your chance of success is more likely when you have that sort of environment. So again, that's really an organization issue when you're looking at the work systems, about how the work is shared throughout the organization. I guess lastly, just look at maybe some of the drawbacks of the paper is that the review certainly only considers interventions that have been published, and in this area, there's certainly, it hasn't been exhaustive or extensive by any means. 20 papers in a variety of different settings certainly isn't extensive. And as I stated before at the beginning, there really has never been one consistent intervention in long-term care for AMS that has achieved consistent results time and time and time again. So again, these have all been sort of one-off with various components. So again, it's hard to make any hard and fast conclusions, at least I think at this point in time. And again, the definition of long-term care facilities can be somewhat troubling because it can include, things which are really resource abundant and facilities which are quite resource abundant, but then also would include for example, an aged care home in a rural or regional setting, which certainly wouldn't have the resources, say, of something that's up at Royal Park or down at the Kingston Centre. If you are interested in this area in particular, I'd also recommend that you have a look at this document, which is put out by the Centre of Disease Control, again in America. And it's a summary of core elements for antibiotic stewardship in nursing homes. And they've gone through, and there are 7 core elements. And again, that's based on some work that's been done in acute care hospitals, but again, also done some work that has been done in long-term care facilities where, in fact, it's available. And that is all. Thank you.
Thank you, Leslie.
Leslie, how do you think this fits in with your evaluation of the Australian healthcare setting in your review?
It was good to see that what we are trying for my PhD does fit into what works, which when you get a paper that comes out, 2 years into your PhD, which says, well, this is what you should actually be trying. I was a bit frightened to read it at first because I thought maybe we'd just gone down a complete, wrong turn. But so I was relieved that, what we are trying does fit into that. And certainly we've tried to take, the multidisciplinary approach and really recognize the power of the nurse staff in particular in aged care homes. And I guess that built on some of the work that was done by a PhD priors to me, who identified that nurses were important in AMS and long-term care facilities in particular. So I guess I was relieved as more than anything when I read the paper that it does sort of fit.
But it doesn't really, in terms of the human factors, the sort of work that you're doing around nursing staff, it doesn't drill down to that sort of element of this paper, does it? Not in particular. It was more, they were more concerned about the communication that was being done between, not, I guess. So we're looking at things like the theoretical domains framework, which is more of an individual factor thing like within your own practice. So this paper was more of a system-wide approach. So they didn't look at things like fear and, individual knowledge of the individuals who were working, with the residents of the aged care home. It was more of a systems approach. So how do people fit in with the bigger system? So I take your point that it didn't drill down as far. It was more of a system-wide approach. And I guess the final comment is that they don't talk about implementation. So it's one thing recommending all these tools. It's quite another thing to implement and have them taken up.
Yeah, absolutely.
So that's a big gap.
Yeah.
And that's always a problem with these sorts of papers.
Yeah, absolutely. But the implementation side of it is,
is kind of another thing. And I guess that's, and I guess maybe that's the point I was trying to make a little bit with about the hierarchy and the etiquette. And those are very individual things which exist within organizations. So sometimes it can come down to even just individuals who are working there within the organization if they don't take up the cause. And there's somebody who, is quite high up in the hierarchy, it can be very difficult. And I guess that's where the lack of consistency and consistent approaches in this space, it just doesn't exist. So there hasn't ever been the same thing tried twice. So it's 20 different papers, and there are 20 different ways that they've gone about trying to do something with that AMS and long-term care facilities. So, it's apples and oranges all the way. But, I think there was a little bit in the paper around looking at the organization and the actual people themselves, instead of maybe trying to put in tools and tasks and stuff, which can be, again, resource dependent. That can be difficult.
Leslie, I think one of the things you mentioned that they said made a difference was posters and educational materials. Were they advertising posters or instructional posters?
They were more posters which supported the education that was delivered. So there was lots of different types of education. Again, it's all apples and oranges in this space, right? So anything from, for example, the algorithm that Loeb did, which is kind of maybe the first and most famous study in this area. So they all had a pocket guide. So it wasn't necessarily, and they all carried around the pocket guide with them. So that was an example of one of the enduring materials that even after they'd received the intervention on, the UTI algorithm, all the nursing staff were supposed to have this pocket guide with them at all time. So that's one example of what they've done. Can't remember any specific example about the posters, but even, again, the Monash study, they were mailing people guidelines. So presumably you have those copies of those guidelines with you forever and ever and ever. So I'm sure there is, when they talked about the effectiveness of education and the need to have enduring materials, they do recognize that there is a tailor off, that everyone comes out of the education all excited to do these things, but there will be a dip eventually. And I don't know that a poster on a wall is going to fix that. Okay. Excellent.
Thank you, Leslie, and thank you to those who attended online. The next NCAS event is the National AMR Forum in Brisbane on the 3rd of November. Information on the forum is on our website. Thank you and see you then.